Good evening, everybody. It is 7:30 and welcome to the July Open Hand webinar. I can't believe it is July, but welcome. And the Open Hand webinars are brought to you in association with the University of the Witwatersrand in Johannesburg, South Africa, as well as the South African Society of Hand Therapists. My name is Kirsty van Stombroek, and I'll be your host for this evening's webinar. Tonight's webinar, we're very excited to be exploring the claw hand challenge, how to regain function after an ulnar nerve injury at the wrist. And we have two wonderful presenters, Gabi Chipkin and Vicki Hofmann, who will be presenting 20 minutes each. And after that, we'll have a time for questions and discussion. If you have any questions, please feel free to contact us at info@Open Hand Therapy. If you have queries related specifically to CEU points, please contact admin@openhandtherapy.org. But without further ado, I'm going to stop sharing my screen and introduce you to our first speaker. So Gabi Chipkin, I had the privilege of meeting Gabi at Wits University, where she completed her undergraduate occupational therapy degree in 2019. I knew Gabi as a professional, ethical, and passionate OT student, and had the pleasure of conducting research with her on a study around lymphedema practices of therapists in South Africa. And Gabi worked at Chris Hani Baragwanath Hospital after graduating, which is the third largest hospital in the world, where she gained very valuable experience before moving into the private sector. Gabi has worked for the last couple of years in a private hand therapy practice, and she's well acquainted with the challenges of working in hands as a relatively young therapist. And Gabi is committed in numerous ways to contributing to her personal and professional community. And thank you, Gabi, for so generously sharing your experience and expertise with us this evening. Please go ahead and share your screen, and we look forward to hearing from you tonight.
Good evening, everyone. So thank you so much, Kirsty, for that very sweet introduction. I don't think much of it is true, but thank you anyway. But I'm very excited to be able to share this topic with you guys this evening. So we're just going to go in and discuss some of the challenges we have with the claw hand, specifically the ulnar nerve at the wrist level. Just to some of our learning objectives for this evening. Sorry, there we go. It's just that we'll be able to kind of understand the basic anatomy of the ulnar nerve at the wrist level, then be able to describe the motor and sensory functions that the nerve provides to the hand, also to identify and assess clinical features and specific muscles and sensory functions of the nerve, and then be able to describe some basic treatment principles and splinting to be able to assist patients with this kind of injury. So to start quite basic, in order to understand what the nerve does, we need to understand where the nerve comes from and what its function is. So in terms of the ulnar nerve, it's derived from the brachial plexus, and it passes down through the shoulder and kind of down the forearm, and that's really where it starts working, is in the forearm. And it gives rise to two different kind of innervations of to two different muscles, but really the work of the ulnar nerve is exclusively in the hand. And if you do have any kind of issues with the ulnar nerve, your main problem is going to be hand function. So to see this picture, it shows a little bit better, but the yellow part is the nerve coming through the hand, and it supplies almost all the muscles and some of the feeling of the hand. And why the nerve is actually so important, of course, motor and sensory function, as we know, for our entire body is important, but the ulnar nerve specifically really controls our hand function and coordination. It's essential for positioning the hand, and it also, like, just to show you with my hand, it's essential for your flexor muscles kind of do this, but the ulnar nerve helps to position the hand for function, and it furthermore also modulates and controls through neuromuscular feedback how much pressure you use, your fine motor control, and all those like subconscious functions in order to make you successful and be able to do the task at hand. So essentially, without an ulnar nerve or with an ulnar nerve problem, people are going to really struggle with their hand function. a little bit technical, but what I really want to focus on is not really the names and of what the muscles are specifically, but to rather look at the pictures and just see those the muscles of the hand are quite small. So it splits into extrinsic muscles, which are the muscles of the forearm that are in the forearm but kind of operate and move the fingers. But then you also have intrinsic muscles, which are muscles found directly in the hand and also contribute to hand function. And you can see that these intrinsic muscles are very small, but they have very specific functions. They hug the bones, they hug the metacarpals, and each of them have a very specific role in terms of what they need to do to make our hands work. I'm going to go into each of them a little bit later and show how we can assess them. But those are just basically the muscles. And without these muscles, which contributes for about 90% of the hand, it's very difficult to be able to use your hand. We know that nerves have both a motor and a sensory function. So the sensory function of the ulnar nerve is that this colored in part on the screen, but it kind of contributes to feeling almost always of the little finger, both sides of the hand, and half of the ring finger in most people. You do get differences in some people do have the whole ring finger, but often it is half of the ring finger. And because patients struggle to feel, it's very easy for them to describe where they're feeling it. So they will often come in if they have a problem and say, I can't feel right here and it's half my finger, because it's quite obvious where they can't feel. And then obviously with sensory distribution, if you can't feel nicely, again, it's going to affect your manipulation, your ability to manipulate, feel things, understand. So both the motor and sensory abilities, if they impacted, really make it difficult for people to do their daily tasks. So then at the wrist specifically, reasons or causes of why people can get injured at the wrist level. And one of them is the most common often is direct trauma. And this could be from falling, from a stab wound, from a fight. And a lot that people often overlook is a wrist fracture. Often if there's an ulnar bone component, that can affect the nerve, or just a wrist fracture in general. You can also get it from repetitive stress injuries or repetitive force onto a specific area. And this is, you'll see quite commonly in cyclists, people who cycle, they put a lot of pressure on the side of their wrist and they can get ulnar nerve irritation. Or you can get ulnar nerve irritation from a compression or mass or different kind of anatomical variations. What patients will come and describe to you, because it's quite noticeable to them. It's not something that they wouldn't notice. And obviously it's on a spectrum. It's not going to be that every patient who has an ulnar nerve problem is going to present with every single symptom. And it's also going to be, some are going to have it very mildly, some are going to have it very severely. So it's important to understand what are some of the things they could present with in order to identify it properly in your patient. So some of the things that they'll come in and describe to you is some sensory disturbances. So they'll discuss or mention to you they have some numbness or tingling, pins and needles, or their finger just feels different, and they might have pain or a burning sensation running up the arm or into the hand itself. They will also complain of motor weakness. So people will say, I'm dropping things, or my grip isn't strong, I'm struggling to open jars, or struggling to do my buttons or press my car keys, small things like that. They'll specifically say things that they're struggling with in terms of weakness. Another thing that they'll mention is, or it's quite linked, is fine motor skills, that they just feeling, they'll say they'll feeling clumsy. Or another one is that they feel that if they stick their hand in their pocket, their finger gets stuck. So that's another thing that people might mention. And then one of the most obvious kind of signs of an ulnar nerve injury is the claw hand deformity, which we're going to discuss in detail now. Okay, so how would you assess that? So although a patient may come into the clinic, they might describe a few things. How are you going to assess and confirm whether this is an ulnar nerve injury or not? And we're going to just discuss the motor and sensory aspects of that. So this is what we were talking about, the claw hand. And often they'll present with a bend in the little and ring fingers, and the other three fingers will be okay. As I said before, it's not, if you can still have ulnar nerve irritation without this. It might be not as pronounced. They might be able to extend their fingers, but we'll go through that and show examples of that as well. But the reason that this happens is, if you can even practice on yourself, is there's a fine balance in the hand between the extrinsic muscles that come from the forearm and the intrinsic muscles of the hand. And both of them work together to kind of create this harmonious effect and be able to allow us to use our hands effectively and in different kind of ways. But the problem is if you have an ulnar nerve injury or irritation, the intrinsic muscles are not going to fire, which means the extrinsic muscles from the forearm are going to overcompensate. So normally, if you have would be extrinsic muscles like your flexors or being able to move your fingers, and normally your intrinsic muscles of guided by the ulnar nerve will be able to straighten your fingers out like that to allow you to curl around. But what happens is when they're paralyzed is that you try bend forward, but there's almost that this normal balance of the hand doesn't kind of open up. And that's where they try so hard to kind of extend that they get this claw deformity. But it's quite a complicated anatomical explanation, but basically it's because there's an imbalance of the muscles and it leads to like an hyperextension and clawing of the little and ring fingers. So to assess the specific muscles, the one muscle that the ulnar nerve innervates is the interossei, and they found in between the metacarpals here. And what they're responsible for is finger abduction and adduction, so opening and closing of the fingers. So how to assess this is you need to ask the patient to open and close their fingers, but it's really important to ask them to do it on a flat surface, because when those muscles aren't firing, they're going to compensate by using their extensors. And I'm going to show you just a little video here, is that if you open and close the fingers, you'll often see that it'll show it now, but they'll compensate and lift their fingers up like that. It doesn't have to be as severe, obviously, but it might be a little bit just off the table. So it's important to remind your patients to keep their hands flat and then try open and close their fingers. Another thing that you can ask them to is to cross their fingers over each other. And obviously, if they're not able to open and close their fingers and cross the fingers over one another, it would be a sign of nerve injury or something's wrong with that muscle. The next muscle that you would kind of need to assess are the lumbricals, and that picture quite nicely describes that they also sit hugging the metacarpal bones, but then they're attached to the top of the fingers, and they really most responsible for the positioning of the hand. To ask a patient to kind of be able to do this, a surgeon once told me, and I quite like the explanation, is to make a tabletop versus a tent. So you can ask the patient, you can demonstrate to kind of make a tabletop that you could really balance something nicely on instead of a tent. Obviously, with an ulnar nerve injury, I'm going to play the video now, but it's going to be difficult for them because this muscle isn't going to innervate. So they might not be able to get it, and they're probably going to claw or do something a little bit funny to try and get that position as well. And most common is they're going to hyperextend at their MCPs to try and get that movement. Another muscle that you'd need to assess, and this is kind of one of the famous ulnar nerve assessments, it's called the Frohman's test. And what you do is to assess the thumb adductors, you ask a patient to grip a piece of paper and between their index and their thumb, and then you pull it away from them. And if they're able to maintain that position of a straight tip of their thumb, their nerves intact, and if they kind of bend excessively to compensate, it's almost one of the signs to show that that nerve is not working. And it's quite nice because you can use a lot of things it doesn't have to be a piece of paper, it can be another thin object, like it's quite easy to find something to kind of use this assessment. Another thing that you can use is just observation skills. So another one of the muscle groups that the ulnar nerve innervates is the hypothenar muscles here, and those are really kind of responsible for helping with opposition, and you'll see it in the bulk of the hand here. So if you can see at the bottom of the screen, there's a nice part where it says wasting of the ulnar border. You'll be able to see that again. It might not be as severe, and a patient with a recent one might not have it, but it's something to look out for. And then they'll also have wasting of the back of their thumb here, and that's because of the other muscle, the first dorsal interossei. So they'll have, if you put both hands flat on a surface and you observe them, you'll often see an indent or wasting of the back of the thumb here, and a little bit of the side of the palm here. Another one of like an accepted, or I've gone blank on the word, but kind of like a clinical test you can see, it's called the Wartenberg sign, and it's again linked to testing the inter-arsal when you ask the patient to open and close their fingers. But this, like if you ask the patient to put their hand flat on a table, they might have excessive abduction of the little finger without being able to pull that in. And again, they'll compensate by extending that finger. So if this is a flat surface, they'll often do something like that to get the finger out, instead of being able to open and close the finger like that. And this is most commonly patients who present with this will complain about their finger getting stuck in their pocket or getting caught when they try to get something out of their pocket. And then another way, because one of the signs is a muscle weakness, you can assess a patient's strength. So this is just describing the way you would assess with a JMAR. So that's a specific muscle strength test, and you just have to have the patient sitting with their elbow bent at 90 degrees, kind of like this position. You hold it like this and you squeeze. But often in settings, it's not always it wouldn't be viable that you would have a JMAR or dynamometer or pinch gauge. So another thing that you can do is just ask the patient to squeeze both your hands. So you can hold the patient's hands and ask them to squeeze and kind of compare that. Or you can do strength related tests and see how they manage. And you can also just, I would kind of document that and then kind of use it as a standard to reassess their strength every few sessions, depending on what you choose. So that was quite an information overload because it was a lot of anatomy, a lot of muscles. But to kind of bring it all together, this is a video of a patient with ulnar nerve fallout. And you can see they'll be able to make a really good fist. But as he opens his hand, you can see that struggle and that hyperextension of his fingers at the MCPs. So you see again, he's able to make a fist, but the second he extends, you can see how those fingers claw as they're trying to compensate, and that hyperextension. Then now this is what I was chatting about in terms of trying to get them to open and close their fingers. You can see how he compensates by extending the fingers off the table there as he's trying to get the movement. And then this is that table to tent, what we were trying to discuss. You're trying to ask them to make a table top, but you can see that he's struggling and those fingers aren't able to straighten at the IP joints. So that's typically what a patient with an ulnar nerve fallout would present with. But again, the reason you have to know all the different muscles would be that they might not present with all of these so clearly. So it's good to understand which muscle groups to kind of look for and then be able to assess them to see if they're intact, if they're weak, if they're not intact. So then another thing we have to look at is the sensory function of the hand, what's happening there. So with typical sensory testing, like the textbook example is to use monofilaments, and that's the picture on the far left. But again, it's not necessarily contextually relevant to everyone to be able to have monofilaments. But if you are using monofilaments, they're specific little filaments of different, I would say strengths maybe, but they kind of assess different sensory modality, so between light touch and pressure, and you'll be able to understand where your patient is feeling, but it's not always relevant. So another way that you can do that is you can trace your own hand or keep a printed chart like this, just of the back and the front of the hand, and use different colors to kind of mark and monitor where the patient is. So because the nerve only regenerates 1 millimeter per day, it can take up to 18 months to get feeling or nerve generation back. So it's not going to be something that's going to change drastically, but it's good to keep kind of a record of where the patient was at every few sessions. So what you can do is I'll just show you in the next slide, but there's different ways to assess without using monofilaments. You can see in the top left, we've used a paper clip and we've opened it up just to have two different prongs, and you can use that for 2-point discrimination. You can use something like a needle or something a little bit sharp if you don't want to prick your patient for pain or for them to be able to feel something a little bit stronger. You can also use light touch of your own hands or different materials, and then you can also use deep pressure. Again, with different materials or with your own hands. But just going back to the slide, the way you do it is that you have to tell them to close their eyes. They can't look. And the reason is that patients will compensate with their vision to kind of interpret the touch. So they have to have their eyes closed, and you kind of say, can you feel this? And they should say yes or no. And then you can go a step further and say, where did I touch you? And then they have to point with the other hand where they felt that sensation. And then you can see, was it completely off? Was it where you did touch them? And then you can kind of understand how much they're feeling from that. And then it's quite important to obviously compare to the unaffected side. An example of this is maybe people who use their hands a lot, manual laborers. They often can't feel the lightest touch just because they've used their hands. So it's always good to compare to the unaffected side before it's kind of labeled as an issue. Another thing is also that to do what I couldn't think of the clinical word, it's not called a ghost test, but to kind of see that the patient isn't just saying yes to please you. With their eyes closed, you will just say, can you feel this? And you don't touch them, and see what their response is. Their response is, it's obviously supposed to be no, but it's just to show you that they are actually interpreting what you are assessing. Okay, I'm just skipping past that one. Another big question is often, how do you explain to patients what's going on or what's happened to them? Kind of taking those medical terms and simplifying them. The nice thing, I don't know if it's nice, but kind of a positive of the ulnar nerve is that the patients will probably have noticed it already, because they either won't be able to feel, or they'll have numbness and tingling, or they won't be able to do what they could do before. So a nice way is that they probably will already know that there's something wrong. But a nice way that I like to use to explain it is to say that the brain is like the electricity box, and all the wires that come out of it are the nerves. And those wires go to kind of supply the muscles in the hand. And if someone had to step on one of those or cut one of those, depending on how the patient was injured, was it compression, was it a laceration, or something like that, and now obviously that electricity can't fire through, and that's why your hand or fingers or arm isn't working like it should be. And then depending on obviously their medical management, you could then say they've repaired the wire, or we're giving the wire time to kind of fix itself and grow back together. So that's just a nice way I like to use to explain what's happening. Okay, just to briefly discuss then, that whole chunk was just assessment, a basic understanding. You're just kind of going to see how they feel, see if their muscles are intact. But then the main part is, now that you've identified that they have an ulnar nerve fallout or issue, what to do in terms of treatment. So the main thing that people do is a splint. And the reason that you do the splint is because you want the patient to be able to control and move their fingers nicely. So the splint, it's called an anti-claw, or it's sometimes called a knuckle duster. And basically what it does is it aims, instead of that hyperextension, it aims to block that hyperextension by pushing the force down, and then naturally it extends the fingers when you put that down. So it kind of acts like the lumbricals, the muscle that would have done it. So it assists in function of the hand. The thing about the splint, it looks quite simple to make, but it's actually not the easiest splint to make. And reason being is that you have to have quite a few key points of control. The first being, it has to fit quite snugly in the palmar arch here, but it can't obviously block their ability to flex their fingers. So it needs to fit within that arch, but not block it. Another one is it needs to fit quite nicely over that part of the hand. So I'm going to play the video again, but it needs to fit nice and snug. It can't be too thin. The bar can't be too thin, because the patient will be able to overpower that, and you don't want them to be able to. Another one is that you want it to be quite low down on the wrist there. So you don't want it sitting up here. You can have it as far down, because that means your forces will be there. So one of the lessons that I always learned in terms of understanding splint forces is, if the fingers are like this and you want to push them down, you need a force there and a force there and a force there to maintain that. I hope I haven't lost you guys, but that's where your forces will be, which is why they have the splint as is. But it's quite hard to explain over online and without practicing how to make a splint. So I will include a YouTube link. There is one in the notes that are going to be sent out. But again, it's something that you do have to practice. But again, taking into context that not everyone is going to have splinting material or access to splinting baths or things like that. So other nice ways that are reported in literature is the top one is you can use like sports tape, or like thick medical tape, and you kind of do it like in a loop formation, and you pull those MCPs down and you stabilize it there. So yes, they will have active movement, but it will kind of encourage them to always keep making a fist and kind of encourage that more functional position. Another one described is to use elastic bands and little leather straps, but you can make those out of anything, almost like a dynamic splint, and pull that MCP down and attach it somewhere on the wrist to kind of stabilize. So those are just different ideas. The reason that the splint is also nice is often with an ulnar nerve, patients aren't always operated on, so you have to wait up to 18 months for their nerve to recover by itself. So it's irritating for patients because functionally it's very hard for them. So the splint is really nice because it gives them a lot of their function back while they're waiting for their own nerve to grow. I've also just included a nice little picture of the way Orford describes it and another company. I'll show you now just how to make this, and it would be a good thing to kind of practice by yourself. So this is just another example to have in your notes of different ways to kind of make the anti-claw splint. Then in terms of the sensory treatment, depending on how, like there's again the continuum, patients might only have some diminished sensation that's affecting their fine motor control. They might have no protective sensation, and they might have no sensation at all. So based on what, if they have no sensation at all, they won't be able to feel anything. So then you need to educate them that they need to look at their skin, be careful of hot water, monitor for burns, monitor for cuts, and just be careful of that while they wait for their skin or their feeling to come back. In terms of the treatment, Vicky's going to speak a little bit more about sensory re-education, so I'm just going to skip over that and go on to motor rehab. And it's quite hard to explain all the different levels and all the different treatment options available, but how you kind of treat someone is what level they're at. So depending on how much their muscle moves, so for example, if they're at a 0 and they have no movement, you can't expect them to have then do active exercises. So the motor rehab will be based on the level of the amount of muscle movement that they have. So for example, if they have no active movement, you'll have to do passive range because they won't be able to activate the muscles themselves, and you'll have to move the joints through that passive range to maintain joint integrity and prevent stiffness. Then if it's between 1 and 2, so they have some flicker of movement, but they're not able to do the movement fully, you'll have to do what they call active assist exercises. And this is when the therapist places the finger in a specific position and the patient is then asked to hold that position. So for example, if the patient can't open and close their fingers, you might open the fingers for them and ask them just to keep it like that and try get their muscles to engage. I'm just going to show 5 seconds of this video because we're running out of time.
You want to try and keep those fingers together, then you're going to come into left hand. Okay, I'm going to let go. Can you hold it for me?
But it just kind of nicely explains how you would get a patient who doesn't have full movement, how to kind of hold that position and train that position, although they don't have the full movement. Okay, I'm just going to cut it there because we're a little bit short on time. And then if they have almost all their active movement, then you're going to start doing things to kind of improve their muscle strength and endurance and overall hand function. So before this, you're kind of maintaining their joints. If they don't have active movement, you're just educating them about, you're doing compensatory techniques, teaching them one-handed tasks or things like that. But as soon as they start getting active movement, you're going to train their muscles. But because our goal is occupational therapists, or just in general, it's boring to do repetitive exercises, you need to make it functional for them. And this is just a whole bunch of different examples of different things to do functionally that is exciting for the patient and also within their context. So you can use little pieces of sponges to squeeze between your hands. You can squeeze a kitchen sponge or a pair of socks. You can ask them to hold a piece of paper. You can get them to play cards, isolate marbles, scrunch up a blanket, use paper clips. Other examples include like pinching stuff, pulling marbles out of putty, dressing stuff, buttons, zippers, key doors, anything like writing, painting, anything that the patient would normally do. One of the things we were asked to discuss is kind of how it would affect a patient's profession. it's tough because your hand function you need for everyday life. So as a clinician, this is where your clinical reasoning will have to come in, and you'd have to kind of understand what the patient needs to do most, what matters to them, and kind of use that to upgrade your exercises. I hope that makes sense. And then once the patient does have functional movement and you want to do a bit of strengthening, there's just a few pictures here of different ways that you can make some of your own things in a clinic setting. Use sponges, use splinting material, use elastic bands to kind of strengthen those muscles as well for them to get stronger. Another thing I just wanted to quickly touch on, and this is the last thing, is just obviously with a nerve injury, there's a lot of scar tissue that can form at that site and cause compression of that nerve as a result. So a nice thing to give your patients is what we call a nerve glide or nerve flossing, and that just allows the nerve at whatever level it's kind of functioning at to not get stuck down by scar tissue. And this, like, I would encourage people to either look at this handout or watch. There's plenty of YouTube videos on what to do, but the main thing would be that the patient mustn't do them more than once a day, and that you have to gradually increase as like that has to be pain-free. So if they aren't able to do the whole thing, then to downgrade it. But it's a nice thing for them to add in terms of allowing to also just help support nerve recovery. And that is it. I hope information overload of assessment and treatment for the ulnar nerve hopefully made sense. Thank you.
Gabi, thank you so very much for sharing that very info-packed presentation with lots of practical ideas. Thank you so much. And we're going to move on to our second presentation now. Vicki Hofmann, thank you for also generously giving your time this evening. I have known Vicki for almost 20 years. We studied together at the University of Cape Town. And after graduating, Vicki completed that we do in South Africa. She did that in a rural area of KwaZulu-Natal, after which she moved to another government hospital in a city. And after that, she moved into private practice, where she has been ever since. And at the moment, Vicki runs her own private practice, where she employs and trains a team of therapists. Vicki has served on the South African Society of Hand Therapists and really loves sharing her skills and expertise to develop hand therapy practice. So Vix, amidst a very busy schedule, thank you very much for being willing to present tonight. Over to you.
Hi, everybody. I'm just going to share my screen quickly. All right. Okay. All right. So thanks, Gabi, for laying the foundation of all the hard stuff, the anatomy and the physiology, which I think is so essential. If you don't know your anatomy and physiology and you're in hands, please make sure you review that. It helps so much when making clinical decisions on hand injuries and surgeries. So always start with the anatomy and the physiology. So just a little bit about what I'm going to be sharing today. So I'm going to be introducing a little bit on sensory education, re-education. Hopefully we will understand and apply a basic protocol for the wrist, understand the complexities of combined ulnar nerves, and equip therapists with tools and modalities to use for old ulnar nerve injuries with contractures. Okay, all of these topics are in themselves quite chunky, so I'm going to try and do them justice. So if there are questions, please feel free to pop them in the chat. So having a look at sensory re-education is something that I think we miss a lot in nerve rehabilitation. I even myself used to only start sensory re-education when the patient started to have some sensation. I thought, what's the point before that? But there is a point. So what nerve is repaired? So the hand map in the brain, which you can see on the side there, so each part of the brain supplies one part of the body, and you can see how big that brain supply is to the hand. So what happens is that the brain becomes occupied by adjacent areas because there's now a period of silence from the nerve. So there's no input coming from the nerve supplying that part of the hand. So the brain just decides to rather use itself to take over some other areas. And also, as the new axons grow, they functional reorganization in the brain as a natural process, but it needs to be facilitated by sensory re-education. So what does this involve? It's basically now when you have a nerve repair and this nerve is growing, you're almost starting to speak a new language to the brain. So we need to use our visual and sensory information to learn this new language so that the brain can interpret what it's feeling. So phase 1, which is when the hand is without sensibility. So this is the moment you get your patient in your room straight after their nerve repair, and it involves keeping that brain space open. So how do we do that? What we do is we need to imagine what different textures feel like. And you can touch the area of the hand with concentrated watching so that you're activating that hand map in the brain. You could ask someone else to touch both of your hands. You can also use mirror therapy, which is the concept where you put your uninjured hand in front of the mirror and then you look in the mirror and it appears that you're looking at your injured hand, but it is uninjured. And then you're getting normal sensation and feedback to the brain. The other thing that Birgitta Rosen, she actually developed the sensory glove, which is so interesting. It's a little glove that you put on your hand and it's got little speakers on. So, and then you put these headphones on and every time you touch something, it gives you auditory feedback. So different things sound different when you touch them and you're getting auditory feedback, which then keeps that brain space open. All right, then in phase 2, this is when your axons have now reached the hand, which can take up to 3 months after surgery at a wrist level. So now you know it's long, and it's not always 3 months. It can be longer. As Gabi said, we don't know how long it's going to take, but from a wrist level, it's about 1 millimeter a day. So perhaps after about 3 months, you may have some sensibility in the palm. And then you can start with localization. So you want to start to localize touch. You first do it with your eyes open, and then you do it with your eyes closed. And then only when you have some protective sensibility in the fingertips can you actually start to relearn textures and shapes. So that's the next thing. So once you've regained that sensibility, you're going to start using the same principles as localization to identify different textures, shapes, and objects. And here's some examples. So you can see in the picture, this guy has got his hand behind a little curtain and he is obviously using his index finger, but imagine it's the small finger. You've got to touch a hidden object or shape and you've got to try and identify what you are touching. Sometimes you can pick an object with your uninjured hand and then try and find the same object with your injured hand behind the curtain. So you're getting that double feedback. Also, what you do is you start by feeling, what does the key feel like? Okay, let's feel what these 3 things feel like. Okay, now I'm going to put them behind the curtain. Can I find each of these objects and identify what they are? All right, so that's a very quick, fast overview of what sensory education entails, and it is very important. So don't forget about it. And I know it's easy to when this patient doesn't have any sensation and you're feeling like there's not a lot you can do. All right, here's a little bit of a gory video. I hope none of you mind, but it does show this is actually tendons and nerve repair, but I am just going to highlight where the nerve is. It's towards the end of the video, but it just gives a nice idea of what they are repairing here. So there you can see tendons, more tendons. And there you've got the ulnar nerve. All right. Okay, and then they've got to find the other side of that ulnar nerve. in order to repair it. Okay, oh, there we go. Okay, so moving on to post-surgical management of ulnar nerve injuries in zone 5, which is at the wrist level. So in the first few weeks, so weeks 0 to 3, you need to protect and control the edema. So what are the goals? You need to protect the repair, minimize the swelling, and prevent stiffness. What is the position of immobilization? So this is often, if you have a surgeon that you can talk to, it is super helpful, because I have some surgeons that say, oh, I repaired the nerve under quite considerable tension. Please, could you put the wrist into slight flexion? Or no, there was no tension, you can put it straight into neutral. So if you're erring on the side of caution, I would always go with a little bit of flexion. But if you do get a chance to chat to your surgeon, then obviously that's super helpful. So here is a picture on the side. So you're going to immobilize the wrist in neutral or slight flexion. And I always include the MPs because, again, we want to prevent that hyperextension at the metacarpal and the clawing that occurs with the ulnar nerve injury. How do we control edema? You can use a number of different techniques. You can use elevation, compression, retrograde massage, kinesiotape. So whatever you can get your hands on for that. Obviously, different settings will have different things that they can use. Then, obviously, we are going to maintain range of motion in the shoulder, the elbow, and the digits, but no wrist range of motion. And very important is your reverse blocking, which prevents that PIPJ contracture, because remember what's happening, you're getting that claw. So the patient is struggling to extend those IPs. So they need to extend the IPs against that splint block. So when we say reverse blocking, it means just basically extension against a block. Then you're going to do your sensory re-education in zone 1, as mentioned before, and patient education to avoid wrist extension. So you always want to educate your patient, if you can, on what has happened and why. Why must they wear this splint? What is it for? Because you're going to get a lot more buy-in if they understand why they're wearing it. Okay. And then just a little star there to say that early sensory re-education post-nerve repair improves tactile recovery. And that was a study done in 2023. So don't forget your phase 1 of your sensory re-education. Okay, then we move on to the controlled mobilization stage. If your nerve was not repaired under tension and your surgeon is quite happy with the strength of the repair, from about 3 weeks onwards, you can start to remove the splint gradually for short supervised sessions. So start with protected wrist range of motion with gravity eliminated and forearm rotation. So when we talk about protected wrist ROM, I usually say that between week 3 and 6, you're working towards full range of motion. So you grade it. So do a little bit in week 3, a little bit more week 4, a little bit more week 5, and by week 6, you're working towards full range of motion. So you're not going straight to full range after 3 weeks. You're gradually going to increase that. Continue with your shoulder, elbow, and digit passive and active range of motion. And again, don't forget your reverse blocking to prevent that PIP contracture. Continue with your sensory re-education. And then this depends. So desensitization will come in. It usually comes in when the patient starts to get some kind of protective return of sensation. So that's obviously going to differ in each patient. But the moment they're starting to complain of this burning, tingling pain, nervy pain, that's the moment you can start with your desensitization. Or if they're starting to say that everything feels rough, everything feels painful, that's when you can start to add that. There's no science on when, unfortunately, with nerves, because everybody heals so differently. So you've just got to watch out for those reported symptoms. And then here you can start with your scar care, massage, silicone, and pressure garments. You can also at this stage, I haven't actually written it in, but you can also start with some very gentle nerve glides. As Gabi mentioned, you do get a lot of scar tissue forming around those nerves. And so you do want to make sure that those nerves are gliding through without getting stuck in any scar tissue and gathering around to put compression on the nerve. All right, then this is now from week 6 onwards. You're going to work towards regaining active range of motion, maintaining passive range of motion, and continuing with your sensory re-education. So the goals are basically to prevent deformity and maintain full APROM, basically. So splinting at this stage, we normally discharge the wrist splint by 6 weeks, and we will fit with the anti-claw splint that Gabi has brilliantly explained, and that is to prevent your MCPJ hyperextension. I always get my patients to wear it most of the day and to remove it at night. So obviously they take it off for meal times and bathing and washing their hands. It's easy to pop on and off as well, but I do like them to wear it most of the day during function, because it's during function that they are going to develop that claw. It also helps them with functional tasks because it positions their hand in a better position. Okay, the next phase can only really start when you start to notice a return of the muscles. So as Gabi was explaining, your manual muscle testing, like as you start to notice that there's some return of the muscle, you can begin with that place hold. And then you can progress to active, and then your putties, therabands, and closed pegs. So yeah, so we basically are working to strengthen those intrinsics as they return. There's some, oh, I never mentioned in the last slide, sorry. I got this NMES here, so I think someone's going to ask a question. And I did see someone ask a question earlier about how do you prevent muscle wasting during this phase where there's no innervation of the muscle? And now obviously we know that if there's no innervation of the muscle, we cannot, there's nothing you can do to actively activate it. But neuromuscular electrical stimulation has been used quite successfully to activate the muscle. So what it is, it's an electrode, and it basically directly stimulates the muscle to activate the muscle to contract. Some people have written some articles on using it to actually promote nerve regeneration, but yeah, that's still, I think, a little bit controversial, but it definitely does help with maintaining the integrity and the bulk of the muscle. But I do want to just say that it's very difficult to prevent muscle wasting altogether. Yeah, unless you're going to do neuromuscular stim every single day, which is not really feasible. Okay, so just back to where we were on beginning with the place hold, and then the active, and then the strengthening as we go. And obviously this is going to be related to each time the patient comes in, you are assessing for the improvement and checking to see whether those muscles are starting to activate. And then you've got your fine motor training, which is buttoning, writing, typing. And then you've got work sport specific stimulation. So depending on, obviously this comes into whatever your patient's job or work, or then your sensory education at this stage, you can go into phase 2. Obviously, if the patient has returned some protective sensation, continue with your desensitization, and then you're monitoring for all those signs, your Frohman sign, your Wartenberg sign, and any kind of clawing. So that's also going to tell you how long you need to wear the splint for. All right. Having a quick look at some combined injuries. If nerve repair was performed along with flexor tendon repairs, you actually just follow the tendon repair protocol. So if you have a look on the side here, this is the splint that you would have on for a flexor tendon. So it's very similar to the one you would wear for a nerve repair. The only thing that would differ is depending on what protocol you were using. So if you were using the St. John's protocol, you definitely wouldn't place the wrist into slight extension, and you wouldn't cut the splint down to a Manchester short splint at 2 weeks post-repair. You would maintain the current splint up until the 6-week mark. So not as difficult. I think when it comes to combined injuries, I think we panic a little bit, but I think it definitely is just thinking through each of them on their own and seeing which one is the one that needs the most protection, and you go with the one that needs the most protection. All right, the difficult old ulnar nerve injury that I think a lot of us will face, especially in government, because the patient might have their nerve repair done with a doctor, and then you don't see them again, and they come back for their follow-up, or don't come back for their follow-up and come a few months later with this terrible stiff claw. So as we've already mentioned, it's MCPJ is in hyperextension, then the PIP is in flexion. There's intrinsic muscle atrophy, and there's loss of adduction and abduction. And then in chronic cases, you might have muscle reinnervation, but unfortunately, the cortical movement patterns can stay maladaptive. So what do we do? So casting is probably one of the best things you could do for a very stiff hand. For those of you who don't know what it is, casting motion to mobilize stiffness is basically stabilizing the wrist in slight extension to correct tendon excursion and promote proper muscle re-education, focusing on active, repeated movement to reshape cortical maps. So it's designed for the chronically stiff hand and deformity, chronically stiff hand and deformity, and it promotes mechanical correction and neurological relearning. So this is just a little picture on the side. You've got a little Sims cast, and this is exactly the cast you would actually use for an ulnar nerve. You cast the entire hand, and then you block those MPs into as much flexion as you can get. So how do we do this? In stage 1, you're going to evaluate. So you want to check the wrist, check the MCPs, check the PIPs, measure, what have you got? Educate the patient on the purpose. We need to retrain active movement. We're not just stretching with passive movement. Get the buy-in from the patient as well. Then you're going to do your orthotic design. So your wrist is going to be immobilized in slight extension. Your MCPs of your ring and little digits in maximum available flexion, but it's actually just easier to put all the fingers in. And then you need to reinforce exercises in the cast. So they need to do the reverse blocking for your PIP extension, and they need to activate those lumbricals. So you need to do lumbrical fisting as much as possible. And the focus is basically a conscious targeting of your intrinsics to reinforce that cortical change. So you're trying to activate those lumbricals again so that they learn how to flex in order to make a composite fist. And then in stage 3, once the cast is off, so I mean, the cast can be on for any number of weeks, even 6 weeks sometimes. And you remove it once you've gained what you want to gain. So you remove the cast, and then you can provide your anti-claw splint to maintain the gains that you have achieved, and to obviously support active MCP flexion. And the exercises that you give after this would now be your isotonic strengthening of the lumbricals and the interossei, because you want to maintain that nice position that Gabi was demonstrating, that nice lumbrical position that positions the hand for activity. And then you can bring in your sensory re-education drills again, and you want to begin your intrinsic plus posturing tasks. So holding a jar, your key pinch, all of those different tasks that we need for that kind of posturing. And just a side note, if you are struggling to get PIP extension, if it still remains stiff, you can actually do a cast on the PIP, which is in the top right-hand corner here, and you can actually progressively cast that into extension as well. Okay, and then just a little slide to say that if there is no return of that ulnar nerve and the patient is really struggling and they don't want to wear a splint for longer, there are options. I've had one patient who actually had this bottom one, the Zancoli lasso procedure. So what they actually do is they split the FDS tendon and they put it around the pulley and loop it back on itself. So what that does is it just prevents that MPJ from extending, hyperextending. So it basically pulls that MPJ down, kind of doing what the splint would do. You're pulling those two fingers down, and then it just helps to position the fingers better and prevent that deformity. It's quite a fairly simple procedure, and it is quite successful, but obviously it doesn't give you the nice manipulation that you'd get in the hand. It may prevent the deformity, but it doesn't give that manipulation, that return of manipulation in the hand. Then you've got your nerve transfers and your tendon transfers, which are also options if your patient is not making any progress. And that is me.
Vicki, thank you so very much for another great presentation, your second time presenting for Open Hand. Thank you so much. Vicki, before you go, could we post a couple of questions to you regarding your last few slides? So the first one, how often do you change your PIP cast? And do you not experience issues with pressure points?
So you can experience get pressure points, so you have to be very careful about where you push when you're putting your cast on. So it's, if you're going to take your thumb and you're going to push directly down on the PIP while your cast is setting, you're going to get a nice big pressure point on that PIP. I tend to use the palm of my hand to push the whole finger down when I'm casting, so that there's not one direct point of pressure over that PIP. You can also use a little bit of undercast padding on the PIP if you are struggling with pressure points. I usually change my cast weekly, depending on how much progress I'm getting, but you can leave it on longer if the patient's, it just totally depends on how much progress your patient is making.
Thanks, Vix. And can you clarify, does it have to be a cast or can thermoplastic be used?
So the nice thing about a cast is that the patient cannot take it off. So the problem with a splint is that patients tend to take it off. And the whole point is that it needs to be on 24/7, because you're doing cortical change and you are trying to stretch and lengthen muscle tissue. The other thing is the cast is a lot more gentle on the skin, because remember, when you're casting, you're putting on a stockinette, you're putting on some nice undercast padding, and then you're putting on the cast. It's a lot more gentle on the skin. The plastic can sweat a lot, and you can end up with quite a lot of emaciated skin underneath a splint if you just did not take it off. So yeah, that's where the casting is more beneficial.
Vicki, thank you so very much. And thank you to Gabi and yourself for generously giving your time to improve access to hand therapy in countries like South Africa and for South African hand therapists. Vix, if you wouldn't mind just unsharing your screen for a minute.
Yeah, okay, hold on.
So thank you, everybody, for joining us this evening. It's been great to have you. It's scary to think we're talking about August already, but our next webinar will be on the 5th of August, and we are very glad to say that Sarah Ewald will be joining us from Switzerland to talk about tackling the tingling and everything else, and effective therapy techniques for cubital and carpal tunnel syndrome, so compression of your ulnar and median nerves. So we really look forward to that and hope you'll be able to join us then. Please keep up to date on our webinars. You're welcome to follow us on social media. Otherwise, scan this QR code in order to join our mailing list and to be sent information of upcoming webinars. But until next month, have a lovely evening and thank you for joining.